So now we'll be starting with part 11. So here we'll be talking about capnography. So capnography, it is used to measure amount of carbon dioxide. So carbon dioxide that comes out from patient is measured. So if you plot graph roughly, so this is how it will look. So we will have respiratory baseline here, then we have expiratory upstroke, we have alveolar plateau, then we have inspiratory downstroke. So here we'll be measuring EtCO2, which should be 35 to 45 mmHg normally. And here we have the dead space, and this is mixed airway plus alveoli. So this is lower alveoli, and we have alveoli plus airway here. So this is how a graph will look like. Now we'll see a few capnography graphs. So first one, so if a graph was looking something like this, then it is a normal capnograph. Now if it looks like this, it means there is loss of plateau. Then this is called shark fin capnography, and it is seen in airway obstruction or in COPD. And then there can be reduced waves, which is indicative of hypoventilation or respiratory acidosis. Now we can have more number of waves. This is hyperventilation or respiratory alkalosis. Then we have this increasing graph, which is indicative of extinguished soda lime. So soda lime is over and you have to add it. So this is an indication. Now we can have one more graph which looks like this. So you will have clefts here, which are known as Curer cleft. So these kind of graph, it indicates respiratory effort. So if it is in post of patients, then it is a good sign, otherwise it is not. So this is indicative of respiratory effort. Now we will be seeing composition of soda lime and all. So soda lime, then we have M-salt, then we have barley lime. So soda lime is made up of calcium hydroxide plus sodium hydroxide plus potassium hydroxide plus water. So 15% of water, 80% of calcium hydroxide. Then in Amzot we have calcium hydroxide plus calcium chloride as well and sodium hydroxide. Here, as the name says, we have barium hydroxide and we have calcium sulfate here. So this is berylline. The next graph is step ladder type. So step ladder pattern will be like this. So you'll have a sudden increase. So you'll have a sudden increase, which is indicative of malignant hypothermia. So this is a very important topic. So here we will see tachycardia and rigidity. So the first sign seen will be increased CO2, and last sign that is seen, late sign or last sign that is seen is hyperthermia. Now here in chromosome 19, Raynaud receptors are mutated and therefore it leads to genetic predisposition leading to malignant hypothermia. So treatment of choice will be dantrolene sodium, and it is usually seen with agents like succinylcholine, lignocaine or lidocaine, and muscle relaxants. So these are the agents causing malignant hypothermia. Now, in case of esophageal intubation, we'll see waves like this. It means we inserted in a wrong place, and there will be no CO2 that is actually getting released. So we'll see this waveform. And if there is sudden loss of waves, it means the circuit is disturbed or disconnected, or it can be cardiac arrest in serious case, or it can be venous embolism. So when can you see this stuff, when embolism and all? So in neurosurgery, lap surgery, Fowler's position, and neck surgery. So next we'll be putting patient in Duran's position, that is left decubitus position plus Trendelenburg, and we'll be aspirating the patient. So here mill wheel murmur is heard. Mill wheel murmur. And one more last graph is this, where you'll be seeing like a small trenches, that is of this is of CPR. So basically we will have 10 to sorry so we'll have 10 to 20 mm of EtCO2 and greater than 20 mm per Hg diastolic blood pressure BP will be seen if the CPR is done in a right way. So this is part 11, and next we'll be seeing part 12 in more detail.